All right, we're going to go through examination of the anus, rectum, and prostate in this video. The structure and function of the rectum and anus, which are the outlet of the GI tract, has no hair or sebaceous glands. It contains autonomic nerves and very many somatic sensory nerves. It's surrounded by two concentric layers of muscle. These are sphincters. One is an internal sphincter that has involuntary control, which is controlled by the autonomic nervous system. And then the external sphincter surrounds the internal sphincter, and there is a small section that overrides the tip of that internal sphincter at the opening. This is under voluntary control. Except for feces and gas, the sphincter keeps the anal canals completely closed. There are anal columns. We're going to see this in a picture following this slide, which are folds of mucosa, and these extend vertically from the rectum and end of the anal junction. They're not palpable, but they are visible on proctoscopy. We have increased venous pressure sometimes, mostly with our older adult population, and these can cause enlarged veins, which end up forming a hemorrhoid. So here, looking at the picture, you can see these. Here, looking at this side, we've got some internal hemorrhoid plexus here. You have down here, which can form external hemorrhoids. These are the columns that we just talked about here. We'll go over the prostate in a second. But here you can also see the external and internal sphincter muscle here. The rectum is a distal portion of the large intestine, and it extends from the sigmoid colon and ends at the anal canal. Just above the anal canal, the rectum dilates and turns posteriorly, forming what's called the rectal ampulla. The rectal interior has three semilunar and transverse folds, which are called the valves of Houston, and I'll show those to you on another picture as well. These cross half the circumference of the rectal lumen. Lowest are palpable and can be mistaken for an intrarectal mass. The peritoneum covers the upper 2/3 of the rectum. In males, the anterior part reflects down into an anal opening, forming rectovesical pouch, which covers the bladder. In females, it's called the rectouterine pouch. And here you can see those valves of Houston here and here. The prostate, this lies in front of the anterior wall of the rectum. It's 2 centimeters behind the symphysis pubis. It surrounds the bladder, neck, and urethra. 15 to 30 ducts open into the urethra. There are 2 seminal vesicles which project above the prostate, and these secrete fluid-rich fructose, which contain prostaglandins. This nourishes sperm. 2 bubble urethral glands called Cowper's glands are inferior to the prostate on each side of the urethra, and this secretes viscous fluid. The uterine cervix lies anterior to the rectal wall and may be palpated through it. The sigmoid colon is S-shaped, and this has a course that is S-shaped throughout the pelvic cavity, or within the pelvic cavity, I should say. This extends from the iliac flexure of the descending colon and ends at the rectum. It's accessible to examination with a colonoscope. So that's when we have our colonoscopies, we can see this. The flexible fiber optic scope, which is this colonoscope, is what we use to provide an entire viewing of the sigmoid colon. Of course, this can't be done without cleaning out the colon first, so there's definitely a lot of prep that we have to do with our patients before such a procedure. With children and adolescents, one of the first things we need to ask about, if we weren't there to witness it, is if the infant has passed the meconium. It's really important for us to know that, because this is what indicates that the anal canal is patent, and that's important for you to know. After this first stool, the infant should usually have a bowel movement after each feeding, and this is due to that gastrocolic reflex, which ends up stimulating the colon and moving things forward, the peristaltic movement. In children and adolescents, the males at puberty, their prostate gland, it starts to grow pretty rapidly. It's more than 2 times its size once it finishes growing, and then the size remains constant during young adulthood. With elderly patients, the prostate can start to enlarge during the middle adult years and then continues to increase with age. The hypertrophy, as we know as BPH, benign prostatic hypertrophy, is caused by a hormonal imbalance, and this leads to the proliferation of benign adenomas, and that's why it's benign prostatic hypertrophy. But this can cause urethral obstruction. You can see that, how obvious that is here, where this is a cross section, but the prostate actually goes around the entire urethra, and you can see that it could very easily restrict this urethra and cause all those urinary symptoms we've talked about. Not necessarily in this that we've talked about yet in this presentation, but we have talked about it before. Prostate cancer is more common in North American and Northwestern Europe. The incidence is higher in Black men. It's often not diagnosed, unfortunately, until an advanced stage. Mortality is 2 times higher in this patient population. Some other possible factors could be diets that are rich in red meat, high fat, and possibly related to obesity. Colorectal cancer, there is an incidence that's 20% higher in Black women and men than it is in Caucasians. The mortality rate is also 50% higher in this patient population. These patients should begin screening for colon cancer at the age of 50. With prostate cancer, this is the leading site of malignancy in men, one of the leading causes of death in men over 55 years of age. Many providers, unfortunately, neglect doing digital rectal exams in men over the greater than 40 years of age. The American Cancer Society says that we need to be checking their PSA levels at 45 years if they are Black or they have first-degree relatives with prostate cancer. With cancer detection, we're going to definitely look at and be suspicious with our patients that have had a family history of prostate cancer. If they're complaining about any type of obstructive signs and symptoms, this would be complaints of dysuria, a slow stream, frequency or urgency, urinary retention. And so we're going to do a digital rectal exam. For colorectal cancer, currently it's the second leading cancer killer in the U.S. 60% of these deaths could be avoided with routine screening. The risk increases with age, so screening tests are going to need to be done, and these are a few that can be done. A fecal occult blood test, this tests for blood within the feces, the flexible sigmoidoscopy, the colonoscopy, and then a double contrast barium enema. We can do a scan to look for any abnormalities. Routine questions that we're going to ask: does our patient move our bowels regularly? Some people do move their bowels every day, every other day, some every few days. So we need to know what their regular movements are and if they've changed. Do they have any control over their bowel movements? Do they have any issues with incontinence? How often does that happen per day? What is the color of the bowel movement? Is it black, brown, green, clay colored, frothy? These indicate a lot of different various things that could either be going on with our organs involved in metabolism, or if we have any bleeding going on. We're going to ask what the consistency is, if it's watery, smooth, on and on, what you see here. A lot of that's usually related to diet, but it also can be related to peristaltic movement if we've got issues with diarrhea or constipation or possible infection. Any mucus or pus in the stool? Do they need to pass gas frequently? Are there any changes in their bowel habits? If so, does the patient have any idea what might be the cause? A lot of times patients have a pretty good idea. So rectally, we're going to ask if there's any pain with their bowel movement, any burning, any issues with a fistula. Has the patient ever been diagnosed with one? Any history or concern with hemorrhoids? How were they treated? A lot of times people have hemorrhoids. They don't really treat them, or they use over-the-counter products. Any pruritus, this is itching at the anus for, really it's kind of idiopathic. Nobody really understands what exactly the cause is. Is there blood in your stool? Some patients may not know this. Sometimes there's frank red blood, and that could be related to hemorrhoids or a very low GI bleed. If their stools are black, we're going to be concerned about an upper GI bleed because that could just be blood that's been digested, so it turns black. Have you ever had black or bloody stools? Like I just mentioned, when did you first notice the blood in the stools? Is it bright or dark, as I just explained? How much blood was there? Is it spotting on a toilet paper? It's outright passing of blood with stool, possibly even clots. Does the bloody stool have a particular smell? And I'm going to tell you, poop with blood in it smells really bad. The smell of a GI bleed is something that every nurse only needs to smell once, and they know exactly what it is. Any associated symptoms with a change in bowel habits, such as nausea or vomiting, change in appetite, fatigue, abdominal pain, or cramping? Are they taking any medications, whether it's for the issue they've currently got going on or for any other type of chronic illnesses they may have? They may be taking over-the-counter laxative or enemas they may be using. Are they taking iron pills? Iron pills can definitely make their stool hard and black. Any opiates? Opiates do cause constipation. It's a huge problem with our patients that are on opiates for chronic pain. What's in the patient's diet? Are they eating plenty of fiber? What's their fluid intake like? Are they drinking enough water? And we're going to ask them about self-care. Are they getting regular digital rectal exams and or colonoscopies? And this is also age dependent, obviously. Do they have any past medical history or current diagnoses of irritable bowel syndrome or irritable bowel disease? How is it being treated? Any family history of polyps, cancer, prostate, colon, rectum, anus issues? Any family history of irritable bowel disease? When we're talking about our younger patient population, we're going to ask if there's the patient's parents have noticed any irritation in the anal area, such as redness, raised skin, or frequent itching. Are they having regular bowel movements? Do they seem like they're straining when they're having a bowel movement? Are they potty trained, depending on the age? How is this going? How is it progressing? Has the child regressed? A lot of times children will be potty trained with urine before they are with their bowel movements, so there may be some inconsistency there. So that's not something that would be abnormal, but something that you would note. As far as equipment for the examination, we're going to have sufficient lighting, possibly a pen light, gloves, definitely lubricating jelly, and a guaiac test container. That's for testing for blood. When we perform our inspection, we're going to have our patient in one of these positions that you can see in the picture. We're going to ensure privacy, just like we talked about with the female GU, where we want the patient facing away from the door in case somebody inadvertently walks in. We're going to keep them draped until the last possible moment, give them some privacy. We're going to help them assume one of the positions below. Our males are going to be in a left lateral decubitus or standing position, and our females will be in a lithotomy position or left lateral decubitus position. What we're going to do is spread the buttocks wide apart and inspect the perianal region. If the anus is normal, it should be hairless, moist, with coarse, folded skin. It's more pigmented than the perianal skin. The opening should be tightly closed with no lesions. We're going to inspect the sacrococcygeal area, instruct the patient to hold their breath and bear down. This is the Valsalva maneuver. And there should be no breaks in the skin integrity or protrusion through the anal opening. We're going to describe any abnormality in the clock face terms, like we've talked about a few times in other presentations, most recently when we talked about breast exam. So we're going to use that clock face to report where any abnormality is. When we do our palpation, we're going to forewarn the patient that this is uncomfortable, but should not be painful. Tell the patient what we're doing before we do it. Let them know I'm going to touch you before you actually touch them, because they may jump if it's unexpected. We're going to use a lot of lubricating jelly on our gloved finger and place the pad of our finger gently against the anal verge. The sphincter is going to tighten and then it will relax, and we're going to gently insert the finger slowly and bend towards the umbilicus. This is really important for you to know and why it's highlighted, but this could end up being a very uncomfortable procedure if we don't follow the natural curvature. So we're never going to approach the anus at a right angle with the index finger extended, because this position doesn't promote sphincter relaxation, and it is very painful. We're going to rotate the examination finger to palpate the entire muscular ring. The canal should be smooth and even with no nodules or masses. We're going to assess the tone by asking the person to tighten the muscle, and there should be no discomfort. Again, this is going to be dependent on how you have your finger within there, so it is important that you don't have it straight. We're going to inspect any feces remaining on the glove when we remove our finger and test for that occult blood. When we do a prostate examination, we're going to document the size, shape, texture, mobility, and sensitivity. The size should be about 2.5 by 4 centimeters. It should not protrude more than 1 centimeter into the rectum. It is a heart-shaped, and it should have a palpable central groove. It should be smooth, elastic, and rubbery, slightly mobile, and it should not be tender to palpation. That's important for you to know. Here you have a schematic there on the left of this procedure where we lubricate the finger and insert it with the patient bearing down. The prostate again should feel smooth and rubbery. The shape is either flat or slightly rounded, and we're going to palpate for that median sulcus. The anus, you're going to rotate the finger to palpate that muscular ring and ask the patient to bear down to assess that. The rectum again should feel smooth and have no type of nodularity. And again, hemoccult, any feces on the glove, check for blood. With our infants and children, we're going to look at our newborn patient and hold the feet with one hand and flex the knees onto the abdomen. Again, we're going to confirm the patent rectum by noting the first meconium stool. Usually this happens shortly after birth, so if you weren't there and it's just a very young newborn, a day or a couple days old, make sure you do note that in the history by asking the parents if they had their first bowel movement yet. We're going to check the anal reflex to assess the sphincter tone by gently stroking the area, and you should note a quick contraction of the sphincter, and that's just a reflex. We're going to not palpate internally unless there's some type of history or symptoms that warrant. Again, we're really not going to do this as a registered nurse anyhow. This is going to be something that the practitioner is doing, but we definitely need to know all of these procedures because we're going to assist with them and definitely educate our patients about them. If we do this, we're going to use the smallest possible finger, which is our pinky finger, the 5th finger. We may see some scant bleeding or protruding mucosa, which is not necessarily abnormal. Some common findings that you'll see, possibly a Mongolian spot, which we've talked about in previous presentations. This can be a common hyperpigmentation in Black, Native American, Mediterranean, Asian newborns, and it's not totally uncommon in Caucasians. And diaper rash is also commonly seen within these patients under a year because they're still in diapers. It's not necessarily normal, but it is common, and we can do some education with the parents about changing diapers often, using some type of barrier cream as well. With our elderly patient, we're going to use the same steps as we would with any other adult patient. We will note the fact that it may take a little bit more time to get into and out of positions, respect the fact that a lot of them may have arthritis and have difficulties with the curvature of their spine and have to be use pillows or positioned in a little more strategic ways to make sure that they're comfortable. As they age, things get a little bit looser and more relaxed, so when they do perform that Valsalva maneuver, we may notice a decreased sphincter control. So it is common when we ask them to do such a thing that they do actually have a bowel movement. Abnormal findings, we've got a whole list here. I'm not going to read the whole thing off. We're going to go through a whole bunch of these. As far as abnormal related to the prostate, even though it's common, benign prostatic hypertrophy, which we've mentioned a few times, it is abnormal. It is the enlargement of the prostate. With palpation, we can no longer palpate that median sulcus. Statistically, 50% of men are going to have an enlarged prostate over the age of 50 and 80% over the age of 80. It's going to be boggy and possibly tender due to inflammation and infection. You may find a soft mass, which could possibly be a polyp. If you find a hard mass, it could possibly be prostate cancer. And there's a couple of pictures there. We may come across a pilonidal cyst or sinus. This is just a little indentation, a little pathway that goes to nowhere. And there may be some hair sticking out of it like it shows in that picture, that zoomed in picture. We may come across a fistula, which is an abnormal opening from the internal to the external. You can see there the indurated cord, and you can see the other fistula there on the left. We may have a fissure. It's a tearing in the rectum that you can see there. Those are very painful. Hemorrhoids can be either internal or external. They are the thrombosed veins that we talked about a few slides back. And we could come across rectal prolapse, where we do have the rectum protruding out of the anus. Puritus ani, this is irritation of the anus. Again, it's idiopathic. We're not quite sure why it happens, but it's itching of the anal area like you can see there in the photo. As far as health maintenance, we're going to educate our patients on these things, which are based on evidence-based practice, where the American Cancer Society recommends that our males get a PSA and a digital rectal exam beginning at the age of 50 for most of us, or most of them anyway. And we're going to begin earlier at 45 years if they have that increased risk of prostate cancer, because they're either of the black patient population, or they've got that first degree relative that has had it. The American Academy of Family Physicians say we need to be counseling men between the age of 50 and 69 years about the risks and benefits of cancer screening. They actually recommend against screening men over the age of 70 years because there's not a whole heck of a lot you can do other than make them really worry about it, because the digital rectal exam and the PSA can have false positives or negatives, so we need to take those into consideration. And that's the end.